Hi, my name is Claire Lowe, and this year I will be a senior at Shaker Heights High School. During the summer, I participated in the Science Internship Program, and I worked with Dr. Sharon Mace in the Emergency Department on main campus. The title of my project is An Analysis of Patients Treated by a Rapid Response Team, a high-acuity, critically ill patient population requiring multiple procedures and transfer to a higher level of care. Rapid response teams, or RRTs, were developed to improve patient outcomes by reducing adverse events, specifically those resulting in non-intensive care or non-ICU codes. Beginning in the 1980s, RRTs gained popularity in the United States healthcare system. The overarching objectives ranged from maximizing the climate of safety for medical surgical patients to providing a cohesive clinical approach based on strengthened nurse communication and expertise across the hospital structure. Based on the RRT model, an adult medical emergency team, abbreviated as AMET for short, was initiated at the Cleveland Clinic in January of 2008 to respond to acute changes in patient status. Emergency medicine, or EM, personnel include nurses, respiratory therapists, and physicians. Each group consists of one of each of these professionals. The team must respond to AMET calls within 10 minutes of receiving the page, with the primary aim of catching patients who are rapidly failing outside of the ICU. Due to the nature of AMET's duties and aims, patients requiring AMET's response generally present with high mortality, severe symptoms, which provide a glimpse into an underlying degenerative disease. The often sudden, unexpected onset of symptoms demands an efficient response from the adult medical emergency team. Even under ideal circumstances, trends indicate that AMET patients are generally admitted to a higher level of care. With this in mind, my analysis strove to scientifically support the following hypothesis. If a patient requires AMET care, then the probability of his or her transfer to a higher level treatment unit increases. The methodology of this AMET study traced 2008 AMET calls and analyzed them for patient dispositions, interventions, and outcomes, or mortality. The study included a sample of 959 patients who necessitated an AMET response. In response to an emergency page, AMET caregivers bring the following emergency supplies: respiratory and intubation equipment, an intravenous line setup, a point of care or POCT testing package, and medications. Airway access, intravenous line placement, peripheral and central, and diagnostic testing were assessed to determine the influence of AMET services on a patient's ability to thrive. The AMET patient sample was followed until January 1, 2009, to determine the overall mortality rate. After assessing 959 patient records throughout the year 2008 for diagnostic interventions, intravenous line placements, and difficult airways, overall result analysis yielded the following statistic. Of 959 AMET calls answered in 2008, findings showed that a staggering 91% were admitted to a non-intensive care or non-ICU inpatient floor, while only 9% were treated as visitors or outpatients. The distribution of AMET responses, which necessitated airway interventions, favored pulse oximetry and supplemental oxygen. In 77% of patients, pulse oximetry monitoring was needed, and supplemental oxygen was applied in 73%. 21% needed an oral or nasal airway, 10% needed oral or nasal suction, 8% received nebulizer treatment, in 7.2% of patients, a BiPAP or CPAP was utilized, and intubation was needed in 24% of all AMET calls. The breakdown of patients requiring intravenous lines were bolus IV fluids 47%, second peripheral IV line 33%, and central IV line 5%. With regards to diagnostic testing, 57% needed an ECG, and 23% needed a chest X-ray. Within the category of point-of-care or POCT testing, 51% required blood gas, 42% needed electrolytes, BUN or creatinine, hemoglobin or hematocrit were transfused in 33% of patients, and lactate in 32%. CPR or cardiopulmonary resuscitation was needed in 7.8% of 2008 AMET calls. Only 28%, or about 268 of the 959 patients, remained on their medical or surgical floor, while a total of 72% were emergently transferred to a higher level of care or expired during the AMET call. Immediate transfers during AMET calls were ICU 50%, emergency department 9%, telemetry 5%, operating room 2%, cardiac catheterization lab 1%, and 5% expired or passed away. Overall analysis revealed that, in total, 4% of AMET patients remained on the same floor during their hospital stay, with 96% either transferred to a higher level of care or expired, and that number is including the visitors and outpatients. These graphs summarize the AMET patient transfers. Considering only the inpatient AMET calls with a sample size of 873, transfers were ICU 66%, telemetry 10%, 18% expired, 4% went to the operating room, and 1% to the cardiac cath lab. Of the 28% who were able to remain on their original floor, 86% were eventually transferred within hours when they failed to improve despite initial AMET therapy. Delayed transfers in these 268 patients included 29% to the ICU, 8% to the emergency department, 4% to telemetry, 4% to the cardiac cath lab, and 1% to the cardiac cath lab, and 38% expired. And this slide basically restates the information discussed previously. The bottom line shows that 35% of AMET patients expired by the end of 2008. This graph summarizes all AMET transfers in 2008. As seen, the largest percent of patients requiring AMET care were transferred to the intensive care unit. The data supports the hypothesis that AMET care increases the probability of transfer to a higher level of care. In conclusion, AMET patients present with symptoms which necessitate numerous diagnostic tests and multiple therapeutic interventions. In particular, airway and venous access procedures are most commonly used to promote survival. These patients in emergent condition require transfer to a higher level of care and have a high eventual mortality rate. After the analysis, a number of recommendations can be made. Drug testing has been utilized and has proven beneficial in an ailing patient population. Testing must be expanded in order to decrease the necessity of higher level care and to reduce the rate of mortality. A more efficient process for streamlining and transferring patients to the intensive care unit or ICU should be devised and implemented to expedite treatment among the critically ill. Finally, renewed efforts for patient education are recommended. Patients, specifically those at higher risk for morbid illnesses, should be taught to recognize the chief warning signs of myocardial infarction, or MI, congestive heart failure, CHF, and stroke in order to improve their chances for survival. I would like to thank the Cleveland Clinic's Office of Civic Education Initiatives for giving me this wonderful opportunity. I'd like to extend a special thank you to Dr. Sharon Mace, my mentor in the emergency department, and all of the wonderful people who helped me in the emergency department as well. Also, thanks to Andriana Stevens, my peer mentor, and my fellow interns, Sophia, Natalie, Emily, and Stephen. Thank you for everything, and I really appreciate all of your generous input and help. Thanks.